Welcome and thank you for joining us. I'm Dr. Tom Frieden, President and CEO of Resolve to Save Lives, an initiative of Vital Strategies, and I'm also former director of the U.S. Centers for Disease Control and Prevention. Today, I'm delighted to be joined by Diana Berendt, founder of Core, and Delane Bond, founder of covidCAREgroup. Both groups are actively involved supporting COVID survivors and addressing the needs of the long COVID community. For the past 18 months at Resolve to Save Lives, we've supported the response both in the US and globally. Working side by side with local health departments and around the world, we have analyzed and reviewed the latest science, provided guidance on public health best practices, on containment, contact tracing, vaccines, and community engagement. Groups such as yours have been vital to elevate and amplify the stories of people who have been affected by COVID. Core and covidCAREgroup have helped build supportive communities where survivors can connect with one another and share information and advocate on behalf of the long COVID community. I'm delighted to answer some of your questions sourced from you and your members on long-haul COVID, the importance of vaccines, the Delta variant, and more. We hope today's Q&A will be useful and informative to everyone watching. Thanks, Delane and Diana, for joining me. And with that, Delane, you get the first question.
Thank you, Dr. Frieden. I appreciate this opportunity. My first question is taken from the collaboration of my group members. We have questions or people asking, they're actually blaming the vaccine for causing long COVID symptoms. And that's been a big deterrent for people who are considering whether or not to get vaccinated, who've already experienced COVID and have long COVID symptoms. So do you have any inclination or any way to explain why some people are experiencing worse symptoms after the vaccine?
The best information we have suggests that getting vaccinated is the best way to protect yourself from getting both COVID and long COVID. If you don't get COVID, you can't get long COVID. And what we find is that people suffering from long COVID have a variety of experiences post-vaccination. That's one of the many things that we need to learn more about. There were early anecdotal reports that some people felt better, some people that was transient, some people it wasn't. But fundamentally, what we're finding is that there's so much we don't know about long COVID. But what we do know is that vaccines are remarkably effective at preventing COVID. We also know that it's possible to get COVID even after you've had COVID before. And so people who've had COVID still need to get vaccinated to protect themselves better against another COVID infection. Diana? Oops, I think you're on mute.
I thought that was a great question and something that Core has done a lot of work into. And we found that 45% of our members were feeling better, but 14% were feeling worse. And there does seem to be a problem in that reporting structure, which I'd like to get into in a moment. But my first question is about boosters. That's all the talk right now. First we were told that it's only for the immunocompromised. It might be for a larger group of people. As usual, we are getting very mixed messages from the CDC. Can you please clear up who the booster will be approved for? Are people with long COVID considered immunocompromised? Will they be prioritized for a booster? Who exactly is in that category? Because the immunocompromised definition has been probably not the same as our colloquial definition. When it comes to monoclonal antibodies, it can be defined as asthma or eczema. Anything. So who counts in this category, and will it be a suggestion to have the same vaccine? Because from what I understand, all the doctors I know are mixing them up on the fly for themselves.
Great questions. And I think for questions like this, it's really important that we're frank about what we do know, what we don't know, how we know what we know, and what we're doing to find out the things that we don't know. The CDC recommendation on boosters for immunocompromised people identified 6 specific categories of individual. The category for which there's the most data are people with solid organ transplants, where we know that the protection from the vaccines is quite a bit less strong than protection of other people. There are other categories. The most complicated one are people who are on immunocompromising medications. That's a very large spectrum, from someone who's on corticosteroids for asthma to someone who's on very intense drugs to prevent the rejection of organ transplants. In terms of people suffering from long COVID, unless they also have one of the conditions in that list of 6, they would not be considered currently recommended to get a booster according to the CDC recommendations. There's a lot more data coming out on breakthrough infections, and other countries have recommended boosters for broader groups of people. There are lots of issues with that I think are very challenging. One of them is that we are seeing more breakthrough infections with time, but there are 2 different things going on. One is you've got the Delta variant, which is much more infectious and can break through infections and break through vaccine-induced immunity, and you've got people who are longer out from their vaccination. So whether the increased breakthrough infections is from the Delta variant or waning immunity, we really don't know so far, according to the data that I've seen. There's more data coming out soon. We anticipate more data coming out from Israel, which has a very robust data system. The second issue is what we're seeing is an increase in breakthrough infections, but not an increase in most data sets in severe infections. So that raises the question, well, is what you're going to see first a waning of immunity for infections, then hospitalizations, then deaths? If that's the case, then you may want to give boosters. But this is something that I anticipate we'll be hearing more about in the coming days and weeks. I would go back to, what do we know? How do we know it? We know that immunosuppressed people don't respond as robustly as other people to a 2-dose series. So the recommendation for them is not a booster, it's really an initial 3-dose series. But there are a lot of details that need to be worked out and a lot more knowledge that we need to develop. And I do appreciate groups such as yours, which contribute to gaining knowledge about what's happening. Back to Delane.
So that was a great question, Diana. And I just wanted to share with you, Diana gave me a little inspiration here. We did a survey in conjunction with some questions that your team formulated, and we had 750 total respondents. 97% of those respondents do not feel like they have fully recovered from long COVID. And it's difficult to really break that down because some are just recently diagnosed with their first episode. Some are, over a year into this. But we have, of that group, we have 61% reporting being fully vaccinated. So one of the questions I have just about long COVID, backing it up a little bit, but do you have any indicator about what actually causes long COVID? I've read a lot of research that indicates that, most people have it asymptomatically first, and that the people who are getting more severe symptoms may have had multiple exposures. Do you have any inclination on that?
I wish we knew more about that. I really do. The fact is there's an enormous amount we don't understand about COVID, including about long COVID. To just give you some examples, why is it that about 40% of people who get COVID don't have any symptoms at all, but 1 in 200 people will die from it? Even if you limit to people over 60 or 70 or 80, many people don't get severe disease and some do, even if it's the same strain of the virus. Is that because they got a larger dose of the virus? Is it because of their immune system and some past exposures they've had? Is it from some other feature of the infection? Similarly, for long COVID, as far as I know, we don't yet have good evidence to say what increases your risk of getting long COVID if you've got COVID. And we also see that long COVID, it may not be one phenomenon. It may be multiple phenomena. It may be that some people have an immune system that gets triggered by COVID that then continues to exacerbate their symptoms. There's some people who had COVID pneumonia and who have a lot of trouble catching their breath and recovering from that. There are other people who are having a lot of postural symptoms and people who have difficulty concentrating or brain fog. We can't assume that those different conditions are caused by the same thing. I think we need to do two things. One, understand long COVID more fast. And second, try out different treatments to see what can be most helpful for people, understanding that there's probably not going to be a magic wand that's going to make it go away, that for many conditions that have similarities to long COVID, things like ongoing physical therapy, progressive strengthening exercises, and for some of the very specific symptoms, interventions to try to address those specific symptoms may be the most important.
It's interesting. Your answer is interesting to me. Within our group, we have noticed that self-care is a major piece of recovery. People looking at things like low histamine diet, eliminating junk foods, high sugar foods, chemicals and preservatives and prepared foods, making sure they're getting adequate sleep, managing physical and mental stress, staying hydrated. And one of the key factors that a lot of people are talking about is breath work. Breathing in deeply, it calms the nervous system and helps to settle things down, but it also allows the body to heal. And I'm getting really great feedback from the group members that are participating in these practices and saying they're having almost instant improvement if they can apply all of those, for some people, really big life changes.
Thank you. Diana?
I would say that we have not seen as much success from those methods and are really on a search for a true therapeutic. And toward that end, I was one of the first non-healthcare workers in America to get a positive diagnosis of COVID in early March of 2020. And I had what I call the Tylenol and Gatorade kind. I was not hospitalized, thankfully, and I received Tylenol, Gatorade, thoughts, and prayers. If I got COVID today, I would have no other options at my disposal. We have not developed a single element of a standard of care in the last year and a half for non-hospitalized or pre-hospitalized patients. The only therapeutic that we have at our disposal are monoclonal antibodies, for which I, by the way, would not qualify. Meanwhile, we have paid for them with our tax dollars. They are sitting on shelves gathering dust. Why are we making it so difficult for patients to avail themselves of this early therapeutic, for doctors to be able to prescribe it? And, why don't we have at every testing center a monoclonal infusion center right next door? So you show positive on an antigen test, you go right into door B and you get your 17-minute infusion, which will, very, very soon be a subcutaneous. Why are we not using it?
Thank you. As you point out, there are very limited options for outpatients with COVID. For inpatients, there are more proven treatments, including corticosteroids, which are well documented to reduce severe illness. But for outpatients, as you note, there really are limited options, and one underutilized option is monoclonal antibodies. The challenge with infusion, the challenge with infection control of someone who's known to have COVID has made it difficult, but that doesn't mean it's okay that we're not using them. Because we know that when applied, when given to the correctly selected patients, you really can greatly reduce their risk of getting severely ill, hospitalized, or dying. Now, I think logistically, it's an example of how many aspects of our healthcare system are not optimally organized. But there are also some real challenges. The combination of the need for an infusion and the need for infection control in someone who has confirmed COVID, as well as some of the complexities of the criteria for providing monoclonal antibodies. So someone who's at high risk of complications, but early on in the course of their disease. It ends up being very difficult to scale up, but there are parts of the country that are doing a better job than others at scaling that up, and it needs to be scaled up more.
But we had a partnership with Optum Labs 6 months ago where you would call a phone number, and if you qualified, we would have a nurse at your home within 24 hours for this 17-minute infusion. The logistics should not be something that stand between people being hospitalized and dying and not. That is inexcusable as far as I'm concerned.
We definitely need to do better getting monoclonal antibodies to the people who will benefit from them. Absolutely.
And almost everyone would. The EUA should be completely opened up. It is approved for anyone over the age of 12 with holes so large in the criteria for qualification that they almost envelop the rule. So any doctor with a little creativity can prescribe them, but we're not doing a good enough job on communication and letting people know that this is a treatment that is available to them and not just to presidents and their cronies.
Thank you. Going on to Delane.
So I wanted to pivot for a moment from the actual treatment to prevention. Dr. Frieden, how does the immune system respond to COVID variants if antibodies from the infection or the vaccine have worn off? Is there some kind of a memory in the immune system that allows the body to respond faster, faster and prevent serious illness?
Well, although there's a lot we don't know about immunity to COVID, there is some really good news here in that the immune system does respond robustly and has several different types of memory. Much of this is not measured by antibody tests, and we don't yet know really if the correlation between antibody and protection is strong, and if so, in which people. The immune memory can last for years, and we know that the COVID vaccines are really good at building this memory. The COVID vaccines basically save your body the trouble of having to get infected. And one thing to keep in mind is that for people who get COVID, they're going to have billions of copies of the virus all over their body. And that will continue for a week to 10 days. For people who get an mRNA vaccine, that vaccine will be gone within 48 hours, but it will have taught their immune system how to fight COVID. So we have a lot we need to learn about immunity to COVID, but a lot that we know, including how remarkably effective these vaccines are. If we can just go back for a minute, if we go back a year plus before the trials of the vaccines, we were hoping for 70% efficacy against death. That was our hope. And we didn't think it was likely that the vaccines would be able to sterilize so that people who'd gotten vaccinated wouldn't even get infected. What we got, particularly with the mRNA vaccines, are extraordinarily effective vaccines that are very safe and that continue to show 90+% protection against severe illness, even in the people who got vaccines 6, 9, 12 months ago. However, there are some groups, particularly the immunosuppressed, for whom a 3-dose initial series makes a lot of sense.
Right. Thank you very much.
Diana?
I will add that a recent study was just released a couple of days ago saying that long haulers who are experiencing specifically the more neurological elements of long COVID, which I maintain is probably most of them are neurologically based, actually do not retain their T cells. And I definitively did not. I did not have T cells at 9 months after a natural infection with COVID. So there might be something, perhaps, when we talk about immunocompromised in specific ways, we might have to think more broadly and have a more nuanced definition. Speaking of nuance, let's get to CDC messaging because it has been not great. We are being told first we have the head of the CDC crying on TV, pleading with us to wear masks because the Delta variant is coming and it's so bad and it's so scary. And then 2 weeks later, the mask mandate is, completely taken away with too early, clearly. A genie that is very difficult, obviously, to put back in the bottle. The messaging has been all over the place on every subject. How would you suggest changing that to possibly restore faith in this organization, which is very, very hard to have faith in right now?
I hear what you're saying. And one of the characteristics of trust is that it's easily broken and hard to build. And what we know is that in an emergency, the hardest thing to surge in is trust. I hope that CDC will continue in the direction they've been going in terms of increasing the amount of information they're sharing about how they're learning what they're learning as they learn it, and what the criteria are for the decisions they're making. I'm encouraged by the ACIP presentations. They're available on the CDC website. That's the Advisory Committee on Immunization Practices. And it's really a best practice. In fact, when I was CDC director, we had people coming from all over the world to observe the ACIP and try to replicate that in their own countries. And that tradition continues. It's really good information. It's very clear. It's very transparent. And in terms of messaging more broadly, I think we have to be clear. Tell it like it is.
And to be clear, I think that you're right. I think that the work that's being done sort of on a deep state level, in the best possible way, is great. And we work very, very closely with the CDC, and we helped them create their interim clinical guidelines, which, by the way, need a next iteration to be developed with more guidance on, exactly how to go about this. But it's the messaging from the top that's getting out to, because most people, we might nerd out and watch all of these briefings, but that's not getting to the American people. And that's what I'm talking about.
Yeah, I think really we have to go back to some clear and simple messaging. The vaccines are our best tool against the virus. The masks are an important additional layer of protection, given how infectious the Delta variant is. And just come back to these 2 points.
I would add a third, that if you have been exposed or you are symptomatic, you should isolate and get tested.
Absolutely.
And that was one of their recent changes. And again, that's not being broadcast in as loud a method as should be.
Yeah, I think the concept of layered protection is very important.
Yes.
And the more CDC can talk directly to the media and to the public, the better off I think all of us will be, CDC, all of the folks in DC, and the public. There are still more than 10,000 public health specialists at CDC who devote their life to protecting us. And they're doing really good work, and more of that is seeing the light of day. But they've clearly got a long way to go to make up for what's been a very difficult 20 months. Back to Delane.
So tagging on to the mask discussion, and with schools starting up and various school districts having, again, a variety of mask policies, and parents making other choices that may or may not put other kids at risk, but hopefully the children over 12 are typically being vaccinated. This is what obviously we want to see, but I think it's really important for the parents to understand how long it takes for the vaccination to maximize in the body. So when do people, in particularly kids, right? When do people actually get protection after they've had their vaccine doses?
We know most about the mRNA vaccines, more than we know about the J&J vaccine. And we know from the United Kingdom some very important information about the need for 2 doses. After a single dose, the vaccine was not very protective against the Delta variant. The Delta variant is stronger. It's more infectious. It breaks through more readily. It spreads more readily. So two doses plus 2 weeks is the rule of thumb for to be considered fully protected by vaccination. And now with the groups that are recommended to have a third initial dose, that would be a third dose plus again 2 weeks after that third dose for the immunocompromised population. I am concerned about what's going to happen as schools reopen. We're seeing increasing case counts. There are still low vaccination rates in many communities. And on top of that, you're seeing some places not using masks and some governors even prohibiting masks from being mandated. We know that vaccines and masks are our best tools. If those tools are themselves infected by toxic partisanship, it's going to be really hard to get our kids to school, staying in school, and learning in school. And one thing that we know with 100% certainty from last year is that virtual learning is not very good for kids. We really need kids in school learning in person, and for all of that, we can do a lot working together, increasing vaccination rates, masking, and reducing spread in the community. The other thing we're finding is that a lot of spread is through what are sometimes called super spreading events. And this may be even more the case with Delta, where when you have a lot of people in one place at one time, you can have explosive spread. And this may be why some communities, some states have much more illness and disease than others. We don't know if that increases the risk of long COVID. So, for example, that may mean that if you're part of a super spreader event, you have more or less chance of severe disease or long COVID. These are the kinds of things that we need to know. We have time for two last questions. First, Diana.
So speaking of masking, as a New Yorker and your former position in New York, isn't it a bit toothless to have these masking mandates with still having restaurants open and bars open at full capacity? Because right now they are packed. And I'll just mention that I had to take my mother to the emergency room at 3 o'clock this morning, and I couldn't go in the ambulance with her because the EMT was not vaccinated. EMTs are not considered healthcare workers under this. And the larger question is, what lesson have we learned in the last year and a half that we are currently employing? Because right now it seems like the virus is winning.
Well, I think the more that we're divided among ourselves, the greater the likelihood that the virus will continue to spread. One thing that's quite important is the recognition of the importance of both mask and vaccine mandates. I think you're getting an increasing recognition of the importance of both masks and vaccines, and an increasing recognition of the validity and the importance of mandates in increasing those the uptake of both masks.
If there's such holes in it.
And vaccines. So a policy like that of New York City, if it gets implemented, that you have to be vaccinated in order to go to a restaurant or a bar, is a step in the right direction. That requires a valid vaccine verification system. Last question, Diana?
I think it's Delane.
I'm sorry, Delane, last question. Thank you.
We're throwing them at you so fast. So one of the things I wanted to follow up on with what you guys were just talking about is the really common symptom of anxiety and depression. It's one of the top pieces. And I've had several parents reaching out to me recently talking about how their children are now becoming phobic, afraid to go to school because there's so much misinformation. And I think everybody's still in panic mode. So again, if we can unite that discussion about the safety and the efficacy of the vaccine with the added protection of the masking, I think that that's going to be really, really important. But one of the barriers to this that I hear frequently is that people think that the Delta variant is less virulent, meaning they feel like they're just getting cold symptoms. And if we're just getting cold symptoms, why are we so worried about this Delta variant? I think that there's not enough information or enough news presence, perhaps, talking about the numbers in the hospitals nationwide, especially filling up with pediatrics. But so the question is, why do some people only seem to have mild cold symptoms?
Well, this is one thing we really don't understand, that a lot of people get asymptomatic infection with COVID. Many people have only mild symptoms. However, because it's so infectious, with so many people getting infected, tragically, many of them will get severely ill. Now, this does remain a severe disease primarily, not exclusively, but almost exclusively for people who haven't been vaccinated. So vaccination remains our strongest tool to fight COVID. And the more of us get vaccinated, not only can we prevent hospitalizations and deaths, but we can also drive COVID down. I want to thank everyone who tuned in today.
One actual thing, because we do know that long COVID can come from an asymptomatic case.
Absolutely, absolutely, and that's another reason we have to reduce transmission. Because the more cases, the more long COVID cases. The more we control it, the less long COVID. I want to thank all who submitted questions, and especially thank Diana Berendt and Delane Bond for their time today and for the dedication they've put into SurvivorCARE and covidCAREgroup. I hope safety and effectiveness of vaccines has been underscored in our discussion, and that we help clear up a few questions and answer some questions, raise some issues, address some confusion or misinformation about COVID, about Delta, about vaccines. It's been a really difficult 18 months. We're tired of this virus. We wish it would just go away. And groups such as yours have been invaluable to the scientific and medical community and to people suffering from long COVID as we seek to understand our challenges that we face with COVID, its impact on our lives, and its long-term effects. You can be some of the best advocates to share information and personal stories on how dangerous COVID really is and how it can impact even the healthiest among us. Your stories go a long way in helping people get vaccinated and in supporting people who are struggling with long COVID so we can protect ourselves, protect our families, protect our communities, and have a healthier future. Thank you very much.